So thank you all for joining me on this Friday evening. I know you guys probably have a lot to do with the holidays coming up, but we're going to explore dermatology tonight. And what I'll do is I'll go through everything, and then at the very end, I'll answer any questions that you have. I also have my email address at the end if there's any questions that we don't necessarily get to. So let's learn a little bit about me first. So I'm a Yukon Husky. I actually did all of my training through the University of Connecticut. I did my undergraduate medical school at Yukon. I went up to Massachusetts for a year and did my internship in internal medicine at Bay State Medical Center. And then I came back to Yukon to complete my dermatology residency. And I'm board certified by the American Board of Dermatology. I do wear a lot of hats though. So I've been in practice for over 5 years, 4 years of which I did at the academic center, the University of Connecticut. So I stayed on as faculty after I graduated. And now for the past year plus, since July of 2019, I've been in private practice. So I've kind of seen both ways of doing things and give you a little bit of perspective about both. So I'm a general dermatologist, which means I see about 40 patients per day, any and all types of patients. We'll kind of go through what that means. And I work 4 days a week. So for dermatology, that is full time. I always like to say dermatologists are allergic to 5-day work weeks and working the weekends. So lifestyle is important to our field. I also am an assistant clinical professor at Yale University, which means I spend part of my time either doing lectures or working one-on-one with the Yale residents in clinic, as well as some medical students that are interested in dermatology. I'm also the associate director of clinical trials. So I have a passion for developing new treatments for skin disease. So I do a lot of trials on these new and upcoming medications, in particular psoriasis, eczema, and hidradenitis, which we'll go through some of these today. I'm also a consultant and thought leader for industry, which basically means when drug companies are coming up with new drugs, they want to talk to people in the field to get a better feel for what do we need in terms of medications. And once they have those meds, how can they best market them to the masses so patients can actually get access to those medications? So I work very closely with industry on that piece. I'm also a partner within my practice, which means besides seeing patients all day, I have to deal with the nitty-gritty of running a practice, dealing with hiring, firing. That's probably my least favorite part of my job, but it comes with the process. And I have to say, after working at UConn for 4 years and having no autonomy to handle the bureaucratic piece, it is nice to have a little bit of empowerment and be able to play a role in the decisions that are made at the practice level. And last but not least, if that wasn't enough things to do, I'm president-elect of the Connecticut Derm Society. That's just a role where I basically help the next generation of dermatologists within the state from a lecturing standpoint as well as a legislative standpoint and help fight on behalf of my specialty. So it seems like a lot. The days are pretty busy, but everything I do because I want to do it, not because I have to do it. And that's what you guys need to remember. Your career can be whatever you make of it. Just make sure you're happy with whatever you make of it. So what is a dermatologist? A dermatologist is a doctor who specializes in conditions involving the skin, hair, and the nails. How do you become a dermatologist? You do 4 years of undergraduate education, 4 years of medical school. Now, there are some sandwich programs where you can do 6 to 7 years and get both your undergrad as well as your medical school degree. You do 1 year of internship, which could be in internal medicine, pediatrics, surgery, or a transitional year, which is some combination of those. You get a little bit of everything. And then 3 years of a dermatology residency. If at the end of your dermatology residency, you have a special interest in one of the subspecialties within dermatology, you can do an optional 1-year fellowship. The reason I say optional is you can still practice and do all those things without that 1 year. The 1 year is basically meant to tweak your skills in contrast to some fields where you actually need the fellowship. Most surgery, pediatric dermatology, as well as dermatopathology, you do take another board exam, which basically means you can bill insurance for it a little bit differently than people who didn't take the board exam. But there's also other fields like cosmetics, complex medical dermatology, skin cancer, and a whole host of other fields, which really comes down to Are you passionate about something? Did you feel you didn't get enough exposure when you were in residency? And do you want to spend a year just kind of honing your skills on that one niche per se? So let's walk through my shoes for a day. So this is a picture of my practice, Central Connecticut Dermatology. So all the design of the practice, everything was something that we all did as a group, the partners in the practice. So I'm very proud of the final product we came up with. But let's spend a day with me. So the first thing I do when I get in is I log into our EMR. We're very lucky because dermatology has a derm-specific EMR called Emma. It makes life really easy because a lot of our preferences, counseling, medications are pre-populated into the system. When I log in, I see a schedule with different patients and different complaints. And we're gonna go through all these in detail. Like I said, I see about 40 patients a day. So my morning is about 20 patients. So this is nothing in comparison to what I'd be seeing, but we'll go through the most interesting and common things that you would likely see if you were spending a day with me. So Anna is coming in for a new rash that started shortly after she had strep throat. She thought it would go away, but now it's spreading and she's really devastated. She can't even spend time with her boyfriend without feeling self-conscious. You examine her and you find this is the kind of rash that she has. So you see it's red, there's scaling, it's all over. So this is psoriasis. Psoriasis is a genetic disease of the immune system. Basically, the cells are multiplying really quickly and much more quickly than the skin can handle to kind of get rid of them. And as a result, they build up on the surface of the skin. And that's what you're seeing. It's that thick scaliness. It's just the buildup of the dead skin cells. It's not contagious. A lot of times before we understood psoriasis, people would be treated as if they were contagious and exiled, but that is not the case. It does run in families. And there are some treatments that we have right now: creams, pills, and injections. Now, the reason I just brought up these different options very generically is because the injections are what I'm going to go into a little more detail about. But historically with psoriasis, we used to hospitalize these patients. We would wrap their arms and legs and anywhere they had skin disease with creams, put them in a hospital, keep them there for 1 to 2 weeks at a time until their skin disease got better. And then they go through this again, maybe in another couple of months. So it was a really debilitating disease to have. However, now we have a lot of good injectable options that have changed how we treat the condition. So this is one of my patients who just came in to see me this week. The top picture was when she first came and saw me, and she has those psoriasis plaques all over her body. In the bottom picture, that's after 2 injections of a biologic medication. So what are biologics? They are immune modulating medications that target the specific psoriasis pathways of the immune system. So for all of you guys who have taken immunology, there is a pathway where IL-23 and IL-17 hang out. That's the pathway where psoriasis is. And a lot of these medications, the one that she was on in particular, is an IL-23 blocker. And by blocking that particular cytokine, you block all of the downstream effects that then lead to the skin disease. It's really revolutionized how we treat psoriasis, and we went from having to hospitalize these patients to having them live lives where they don't worry about their psoriasis on a day-to-day basis. All right, so how did I treat Anna? I gave her a biologic. So the biologic that she was on is Tremfya, but usually my top 3 that I go to are either Skyrizi, Tremfya, or Taltz. Slightly different mechanisms of action, but the reason I like them is they are extremely effective, as you saw in the photograph, and their safety profile, especially in a COVID era, is excellent. So now let's talk about Brian. So if I can see my slide better. How do I get this to go up? So Brian's coming in for these bumps on his face, chest, and back for the past several years. He's noticed some areas are starting to scar and the scars aren't going away. He thought he'd grow out of it, but he still has these bumps at age 21. So that's one picture, and here's another picture. So this may seem pretty straightforward to everybody out there, but what I want to draw your attention to is how extensive this is and how he does have scarring not only on the face, but as well as the back. So this is acne. We all hear about acne. And a lot of people think that acne is not a big deal. It's a cosmetic concern. Oh, well, you'll grow out of it. We're going to talk a little bit more detail about that. In some patients, that may very well be the case. But in a lot of patients that I see, acne can affect the psychosocial development. It can scar, and that's permanent scarring for life. So it is important for us to intervene. So mostly patients complain about blackheads, whiteheads, cysts. It can be on the face, it can be on the chest or the back. And it can scar whether or not you pick at the lesions. There's this old wives' tale that if you pick, you're going to end up with scarring. The truth is that it's the depth of the acne that determines the scarring, not so much the picking. And it's not just a cosmetic concern. There are various treatments. Usually creams are a first line, then creams plus the antibiotics are a second line. Birth control pill plays a role if there is a hormonal component. And then Accutane is the final step. And I'll go into that in a little more detail. So Accutane is the closest thing that we have to a cure for acne in the year 2020. You can see in this before and after photo how much of a difference you can achieve. But I usually say this is not a magic medication. 2/3 of patients clear and stay clear. But 1/3 of patients may or may not respond. And they may get an occasional breakout or they may go right back to where they were. So it's really important to tell patients this before you start a medicine like this. It does get a bad rep though. A lot of people think of it as a dangerous medication. That's because if someone who's on Accutane gets pregnant, their baby's going to have birth defects. There are also some mental health issues that were brought up when the medication was first studied back in the 70s. And this is where my clinical trials background comes into play. I look at the studies, and what we found in actually analyzing the patients in the studies is that a lot of the depression and mental health effects that they found in those patients was related to their acne and not necessarily the medicine. And in a repeat trial done in the 90s, they actually found Accutane improved those symptoms. Well, that's why you really have to look at the studies carefully to assess the medication properly and do its fair justice. Dryness is another side effect of the medicine. That happens. That's how the medicine works. It kind of shrivels up your sebum glands and your sweat glands. And because of the birth defects, the government does regulate this medication. We're prescribing it in teenagers. They have risky sexual behavior. So the government is like, you know what? I'm going to control this so we have a better handle on who's on this, who's not, and make sure they're being monitored for this, for the pregnancy piece, basically. And what you want to remember is that once a person does get scarring, it is near impossible to return the skin to the way it was before the scarring happened. That's why when I start to see any form of scarring, I have a low threshold to start Accutane. Some parents might think that's overkill, and we have so much laser technology, so I should be able to reverse it. But the reality is, no matter the laser technology we have, we still don't have the ability to bring the skin back to where it was pre-acne. So how did we treat Brian? 2 months of minocycline, which is an antibiotic. And then if he does not respond, I usually start the Accutane. I give the antibiotic a fair shot, 1, because of insurance, 2, because I want to make sure that that's not a viable option. And if it doesn't work, we start the big gun medication and hope that that clears him. Next is Sally, who's coming in for her annual skin cancer screening. She had a basal cell skin cancer about 3 years ago that was treated with surgery. So I see a lot of skin cancer screenings on a regular basis, which initially I was very ecstatic about because it means people are more aware about the risk of skin cancer, especially in people with my type of skin, which is a little bit more olive tone, and people think we can't get skin cancer. But now I feel like the pendulum's kind of swung to the other side, and I have parents bringing in their 6-year-old for a skin cancer screening. So as future providers, it's really important to educate your patients on who needs to see the dermatologist for skin cancer screening and who can probably wait. And usually for children under the age of 20, we don't recommend the skin cancer screening unless there's a reason. Is there a family history? Do they have something funny looking? But in individuals who are older, usually after age 40, I do recommend a baseline screen just to see where their skin is at, and then we can determine how frequently they need to be seen. So as part of the skin cancer screening, we have the patient pretty much stripped down to their undergarments. We look at all of their spots to ensure that none of them are cancerous or precancerous, and we biopsy any suspicious lesions. That device that you see there is called a dermatoscope. This is a really fancy and expensive magnifier that allows me to see the pigment within the different lesions much more carefully. And dermoscopy, which is the study of those individual patterns, is something that helps us avoid unnecessary biopsies. Before we had dermoscopy, we actually did a lot more biopsies than were necessary. Now we can be a little bit more judicious with it. I always say the dermatoscope is similar to the stethoscope that a cardiologist would carry around, basically. All right. And now let's go through some of the lesions that we would see. So the benign lesions, you can see seborrheic keratoses, which are these ugly, stuck-on dark spots. You could see lentigos, which are these flat brown spots, usually due to sun damage. Skin tags, very common. I see it on almost every single skin check. And then cherry angiomas. These are blood vessels that are really high up in the skin. So when I'm doing someone's skin check, given the number of times I've done this, my eyes basically ignored this background benign lesion piece. So when med students see me do my skin cancer screening, they're always shocked at how quickly I do it. But it's kind of pattern recognition. The more you see, the more you get used to the normal and your eyes just disregard it, and your eyes are drawn to the abnormal and those patterns that should prompt a biopsy. So what does skin cancer look like? Those things that I pay a little more close attention to. So on the left, you can see a basal cell skin cancer. So initially it's a little round bump. Patient comes in and says it's bleeding. On dermoscopy, you see these very prominent red blood vessels. And that's where the dermoscopy becomes very important, because you can tell whether or not this is a skin cancer, and you can even tell what type it is from that dermatoscopic look. In the middle, you see a squamous cell skin cancer. So it has that thick crustiness in the center. And then when you look at it on dermoscopy, again, you see some hairpin vessels at the periphery. Not a great photo for you guys to see it, but there is a specific pigment pattern. And then finally, the last one is a melanoma. If you see something like that, you should biopsy it or send your family member to a dermatologist. Usually it looks like a irregular brown spot with different pigment colors. But if you look at the top one, the pigment is different, but again, you may not be overly concerned. But look at the dermatoscopic look. That looks pretty funky. So you have those little round areas, which are foci of growth of cells, which means it's growing. You have that bluish grayness, which we call the blue-gray veil, which again is a sign of cancer. And then you also have that area where it looks like little crystal structures, which are called the crystalline structures. And again, these are all signs that this is a melanoma. If I see this on someone's skin, I cut it out right then and there. I don't even mess around with the biopsy, because you want to prevent it from staying on the skin any longer, because it could metastasize. So how do we treat skin cancer? Depending on the type, there are different modalities for us to use. So topical chemotherapy creams are great for the superficial types. Electrodessication and Currettage, where we scrape and burn the skin cancer, which I'll show you a video of in just a second, that's also good for the superficial ones. Excision is usually better for the deeper lesions. And then finally, Mohs surgery, which is a special technique. It's similar to the excision, but the difference is, this is a little schematic on how it's done. You basically see what you can see with your naked eye, and you just cut that out. You take barely 1 millimeter margins. Then you check it in the lab and you send the patient to the waiting room. If you got it all, you stitch it back up. If you didn't get them all, you keep going back and taking a little bit of skin, so that by the time this is all said and done, the patient is 100% skin cancer free. The benefit is it limits the amount of normal skin you take out. So you're not just taking random margins. And on areas like the face, where the cosmetic outcome is important and you don't have a lot of extra skin to deal with, this is the gold standard in terms of treatment. And this is a little video that will walk you through how we do an electrodessication and currettage. So basically, first we numb the spot that we're going to be treating. And then we use the Currettage to scrape the skin cancer off. We do it in 3 to 4 different directions. And then we burn the base, which is called electrodessication. And we repeat that a total of 3 times until the skin cancer is gone. You might ask, how do I know the skin cancer is gone? As I'm doing that curetting process, the feel changes once the skin cancer is gone. And that's when I know, okay, now I can stop. So moving on to the next patient, Robert is coming in because, sorry guys, let me just get rid of this attendance poll. Because a cyst that he has had for years suddenly started to get red, hurt, and drain in the last few days. It's very painful and uncomfortable. This is something you would see out of Dr. Pimple Popper, basically. So this is an inflamed cyst. Epidermal inclusion cysts happen when dead skin cells get trapped underneath the skin in a sac. If the sac opens up, your immune system starts to see all that dead skin and starts to attack it, and this causes inflammation, pus, redness. The way we treat it could be a couple of different things depending on at what stage they come and see us. You could treat with antibiotics, intralesional Kenalog, which is a steroid, incision and drainage, which means you kind of cut it open and get all the contents out to really relieve the pressure. And then surgery once the inflammation has resolved. So you got to get that whole sac out, otherwise it's going to keep coming back. So this is a video of one of my colleagues doing an incision and drainage. So he's basically using a blade to cut the top of the cyst. This is going to be a little graphic, so if you guys get grossed out, don't look. And then you basically put pressure on either side. It's like popping a big zit. And then you get all that gunk out. And what this really does is it helps relieve the pressure, helps from a comfort standpoint for the patient, but also allows for antibiotics to be more effective, because if a cyst is that big and full, your antibiotics aren't going to penetrate that deep into the actual spot. All right, so next we move on to Sullivan, who's coming in due to bald spots on his head that randomly showed up 4 weeks ago and have been getting bigger. This has actually been a really common presentation since COVID happened. This is called Alopecia Areata. And it's an autoimmune skin disease where the immune system attacks the hair follicles, leading to patchy hair loss. Genetics does play a role, so it does tend to run in families. And it's usually stress-induced. It has a waxing and waning course, so that basically, even though it goes away, it certainly can still come back. And the treatments are a couple of different things. You could start with topical steroids, which are just a cream to kind of calm down the autoimmune response in the area. You could inject the area with a little steroid, which works more effectively. You get the medicine right down to the follicle more quickly. Or you could give them oral medication, medicines that suppress the immune system as a whole. And the downside of that is if it's a hair issue and you're suppressing the whole immune system, you obviously are going to deal with unwanted side effects. If it's more extensive than what Sullivan had, it may be worth it. However, for 1 or 2 patches on the scalp, usually I limit it to the localized approach. So how will we treat Sullivan? Intralesional injection of Kenalog is where I start. So that's usually where I start. I give it 2 rounds, and if it doesn't work, then I consider the oral options. And then this is a schematic to show you how I do the injections. Actually, not 1 injection. For a spot that size, I would probably do 5 or 6, about 1 centimeter apart. And then when you see them back for follow-up, you see the hair growth coming in. It takes a while, obviously, for the short hair to get to the same length as the rest of the hair, but that result shows me the treatment worked, and we just let it run its course, and the hair normalizes after that. So now let's talk about Olivia. I see quite a bit of kids in my practice. So Olivia's pediatrician sent her to us for a growing birthmark. This started as a small red dot at birth and has been growing ever since. She is now 3 months old. This is called a hemangioma of infancy. It's a vascular birthmark, so it's made up of blood vessels. It usually starts as a small red dot. It grows very rapidly for the first 5 months. Then it grows, but it's a little bit more slow of a growth until about 9 months. And then it starts to go away. And I usually say it should be gone by about age 10. The cause could be low birth weight, prematurity, advanced maternal age, twin birth. And the prognosis is pretty good. Usually it goes away without any sort of sequelae. However, if the lesion is large, if it's in a tricky area, it can leave behind scarring and deformities, which is why it's really important for the patient to see the dermatologist ASAP. I personally would like to see the patient as soon as they're out of the hospital, but oftentimes it's misdiagnosed, and by the time they get to me, they're 1 or 2 months old, which we haven't lost a lot of time, but given the 5 months are the rapid growth phase, you don't want to lose too much time before you intervene. So what happens during that involution phase, and what kind of scarring could we see? So this is a child, this is actually a good case scenario where they had this large hemangioma on the cheek and you barely see anything in the after photo. However, in this one, this was a hemangioma that was in the sacral area. And afterwards, you can see there's quite a bit of scarring and deformity still left behind. And then last but not least, in this child's lip, again, it's gone down, but you definitely see those broken blood vessels left behind. So lasers play a really important role in normalizing the skin. Unfortunately, like I said, with acne, you can never get the skin back to the way it was before, which is why it's important to get these patients to dermatologist at the very early stages of the birthmark so we can treat it then so it doesn't get big enough to cause these sorts of side effects. So depending on the location, there's also a risk for other complications while the hemangioma is still active. So on the nose, it could start to involve the cartilage and actually cause deformity of the nose itself. On the scalp and the lip, because of the nature of the location, it could form an ulcer, which can cause the kid to cry, it could cause infection risk, and if it's close to the eye, vision issues can ensue. And in those instances, I work closely with ophthalmology, and I have a low threshold for giving them something oral to help treat this, because obviously vision is something that we can't compromise. So how did we treat Olivia? We gave her some topical timolol gel. This is a product that when you put it on top of the birthmark, it actually prevents the growth of the blood vessels and can help, 1, halt the growth, and 2, reverse the growth. If that doesn't work, oral propranolol, which is basically a beta blocker, but the oral version of it, is a backup option. Again, like I mentioned before, topicals have less side effects and oral medicine is going to have more side effects. So we leave it as a backup. But as you can see in the picture below, in a child that was put on the timolol, the results are beautiful. And if that was not done, I'm sure there would have been some sequelae left behind. Now let's talk about Nelson. Nelson's coming in with this itchy rash. He's had it on and off since he was a child. The creams he's been given in the past just aren't working anymore, and he's looking for a better option. This is impacting his sleep and work productivity. So this is eczema, also known as atopic dermatitis. It's a condition that makes your skin red and itchy. Your skin isn't functioning optimally as a barrier to keep the foreign allergens out. So your immune system kind of gets excited about everything that it comes into contact with. So they get the red rash. And how do we treat it? So the treatment of eczema is twofold. You want to, 1, talk to them about baseline dry skincare. They have to be really good in terms of restoring the barrier and having a good barrier for their skin to get rid of all those allergens that are trying to get in. So you want to use gentle soaps, lukewarm water, and a ceramide-based moisturizer. Then the prescription medications help for where the baseline dry skincare hasn't been helping. We have topical creams, we have oral medications, and we also have the biologics, which are the injections that we talked about for psoriasis. So let's talk about the biologics. Currently, dupilumab or Dupixent is the only FDA-approved biologic for ages 6 and above. It targets specifically the eczema pathway, and it is not immune suppressive, which makes it a great option during the COVID pandemic, where people are definitely suffering from eczema, but also want to avoid medications that can impact their immune system. In the picture below, you can really see why it was termed a life-changing drug, the before and after for these patients. And the one thing these patients really complain about is itch. And this medicine calms down that itch in as little as 1 week. So it is a pretty incredible medication. And there's similar agents coming down the pipeline. So how did we treat Nelson? A combo approach. I would hands down give him the dupilumab, but I also give them topical corticosteroids because I think the steroids do help calm down the inflammation while we're allowing the medication to kick in. And even though people might be stable on a medication that's a biologic, they may still want a cream to have on hand if they get a random flare somewhere. So now let's switch gears a little bit. So Donna's been feeling self-conscious about her face in recent months. She feels like she sees every wrinkle, looks tired, and can see the effects of time on her skin. She wants to discuss options for looking younger and more rested. So we are trained as dermatologists in cosmetics. So this is a routine thing that I get in the middle of my day, patients coming in for either cosmetic recommendations or full-on Botox filler, lasers, body contouring, you name it. And the patients, oftentimes, this is what they expect. If this is there before, this is what they want their after to be. So it can be challenging sometimes to really talk to patients about the realistic expectations of what we can do. Botox is something that's very common for our patients. What it does is it relaxes the muscles of facial expression. It can soften the wrinkles that come with motion. If the wrinkles are present at rest, Botox really can't do much for it. And it's temporary, so you do need to keep up with it. It wears off in 3 to 4 months. The recent trend is actually prejuvenation. I've been seeing a lot of younger people in their 20s and early 30s who want to get the Botox now to prevent the wrinkles when they're much older. I think that's really smart. I started Botox when I was in medical school because I really feel like it does help prevent, and prevention is really the name of the game. But there are still some skeptics out there who may not necessarily want to go that route. Fillers are another way where we can help the skin look more youthful. And in the picture above, you can see the triangle of youth. So what happens is usually our face is an upside down triangle, which basically means all of our volume is focused up top. We have nice fat pads in the cheeks, under our eyes that help everything kind of stay up. As we mature, however, that triangle shifts because we lose the volume here and under the eyes, and gravity pulls down and you end up with that sagging effect. So what we do with fillers is we put volume back where it was naturally. And that tends to give a much nicer result than trying to fill in the gaps over here as the Sol method, which is what we used to do before we kind of fully understood how the aging process worked. So we already went through this. Fillers are temporary. They last about 1 to 2 years, depending on which product you use. And there are side effects. So there are allergic reactions. If you inject a blood vessel, you can cause death of the overlying skin. If you're injecting too superficially, you could have lumps in the skin. The bottom line is you want to see someone who is trained and board certified in doing this. Dermatologists, plastic surgeons, some oral maxillofacial surgery doctors, as well as people who've done a special fellowship in cosmetics, they're good people to go to. The person who did the weekend course, probably not the best person to go to because I see a lot of their complications. And if you're not familiar with the anatomy, you can definitely do harm. So what about Donna? Let's go back to her. What are we going to do for her? So I gave her injections of filler in her marionette lines. I gave her Botox for the 11 lines, the glabellar area, as we call it. And then we did filler in her cheeks to give her that natural boost in the cheekbone area where she had lost volume. And then this is her before. And this is her after. As you can see, it's not a dramatic improvement, it's a subtle improvement. That's what we go for when it comes to the rejuvenation dermatology. I could have put more filler in her face. Obviously, money is an object here, and she had a budget, so I had to stick with it. I could probably have put at least another $2,000, $3,000 worth of filler in her. But the key thing to remember is we're looking for that subtle effect as opposed to plastic surgeons who do more of the, oh my God, nip tuck, where people absolutely know there's a difference. She's also getting her eyes done actually coming up later next month to kind of help with the rejuvenation there. So other cosmetic procedures that dermatologists do, we are trained in chemical peels, all sorts of lasers, body contouring technology like M-Sculpt and Cool Sculpt, and so much more. And this is where it's important to know that about dermatologists, because some people think we're just cosmetic doctors. Some people think we're not trained in cosmetics. So we do have specific metrics that we need to meet in the cosmetic realm, and we're tested on it on our boards. So you are trained to feel more comfortable with it, though. I do usually recommend a 1-year fellowship so you can really delve into it in more detail if that's what you want to do only. I do 80% medical, 20% cosmetics. So for me, not doing a fellowship didn't hurt me. Now let's talk about Doug, who's here for surgical removal of his basal cell skin cancer. So another thing that I do is small surgeries in my practice. So I biopsied the spot last week, and he's coming in after we confirmed it's a basal cell to actually remove the spot. So the first thing we do is we take standard 4mm margins. So that's what you see, the pink, and then you see the line around it is a little bit farther from the pink. That's accounting for the 4mm margins. Then if we cut out a circle, we can't really close it. So we extend the edges and make it a nice ellipse that'll close in a perfect line. And then once we cut out the skin cancer, we stitch it back together. And I'll actually show you a couple of videos on how we really do that. So here's the first step, cutting out the skin cancer. So we cut along the purple line. We want to get down to the level of the fat. You can see those little fat cells kind of poking through. That's how you know you're deep enough, because that's where you stop. You want to go right below the dermis. Once you get to that fat level, you know, okay, that's as deep as it's going to go. And then you basically remove that layer of skin. Now you want to put in stitches to bring the skin back together once you've removed the skin cancer. We call these vertical mattress sutures, and they do a great job at kind of bringing the deep layer of the skin together. And you see how nicely it closes. And something like this would probably need about 3 to 6 stitches in the deep side. And then once the deep is done, some people just leave it. I like to do epidermal closures, which is that one last bit of stitches on the very top layer. And what that does is it really helps it look pretty, and also helps that epidermal layer stay together and not dehisce. All right, and then last but not least, Catherine's coming in for a wart on her finger. It's been there for months, and over-the-counter treatments have been ineffective. She's hoping we can get rid of it. So let's talk about warts. They're caused by the wart virus, which is the HPV virus. There's a ton of them. There's a specific one that causes it on the hands, HPV2. So this is different than the HPV that causes cervical cancer. It requires multiple treatments, about 4 to 6 weeks apart for full eradication. So I make that clear with patients when they first come in. And the treatments could be liquid nitrogen, candida injection, cantharidin, DCA, Fudex or Aldera. Basically, we have a lot of treatments, which means no one treatment works for everybody. So you just have to play around with it and see what's going to work for the individual patient. And for Catherine, we did liquid nitrogen to basically freeze that wart. Usually pieces of it will fall off over 2 to 3 weeks, and they come back in for repeat treatment. So at that point, we kind of break for the day, go to lunch, go home for the day, and you go home and realize you love dermatology. Now what? So I'm going to go through the journey through medical school, because one thing about dermatology is you do need to know early on that you want to do it, because there's a lot you have to do to make yourself competitive. And if you decide in your 3rd year, that might be too late. So show your interest early, get involved with your home derm program, volunteer to work with faculty during your free time, and find a nearby derm program if your medical school doesn't have one. You need to have excellent grades. So from day 1, you better be studying. Excellent USMLE Step 1 scores, AOA status, excellent letters of recommendation, leadership positions, so like the American Medical Association, AMSA, Student National Medical Association, basically any way to show that you're involved on a higher level. Research, preferably within derm. I would say get involved your first year because it's hard to really have a good research project if you're just getting involved toward the end. Some people do a research year just to beef up their application a little bit more. And first author publications, preferably within derm, but any first author publication shows that not only were you invested in the project, but you also took it to the next step and got something published. And then once you match into dermatology, you are going to learn about the skin diseases in adults and children, anything and everything. I just gave you a small snapshot. There are so many cooler diseases that we see. I just kind of went through the most common things I would see in a typical day. Dermatopathology. So it's important to know what the skin looks like underneath the microscope because we biopsy. If you don't know what a disease looks like under the microscope, you won't know how to properly biopsy it so that the pathologist can see what they need to see. Surgery for both benign and malignant lesions, including Mohs surgery. You do have elective time with Mohs surgery. And then cosmetic procedures in adults and children. And then, like I mentioned earlier, if you want to delve into any subspecialty further, you can do that optional 1-year fellowship with Mohs surgery, depending on what part of the country you're practicing in. Unless you're in the boonies of South Dakota, you do need that 1-year fellowship to practice, because if you don't have it, they don't take you seriously as a surgeon. And then once you're done, there's a couple of things you can do with your life. You can do academic medicine and work in a university where you're one-on-one with residents all day, every day. You could do what I do and go into private practice and have the option to teach with residents on a more regimented schedule. Do collaborations with industry, like I mentioned, kind of what I do, where you consult, you do lectures, clinical trials, help develop new medications for skin disease, and legislative efforts. Help shape the legislation that directly affects your patients and specialty, or any combination of the above. Like I said, you can be as motivated to do all this stuff or not motivated. And then this was a cute thing I found when I was preparing this talk. When I advise med students why they should consider dermatology, everyone wants to be us. I found it funny because there is some truth to it. No matter how much medicine sucks and no matter how many rules and regulations come down the pipeline, it always sucks a little bit less for dermatology because you have the option of doing cash-only cosmetics to kind of make up revenue, and there's a lot more autonomy. You can do a lot with your 4-year degree. So it is definitely a phenomenal field. But in all seriousness, to be happy with whatever specialty you pick, you need to find the glove that fits your hand. Don't try to change your hand to fit the glove, because remember, you're going to be doing this for the next 30, 40 years of your life. So you want to make sure it's something you enjoy doing. It's not something someone else kind of made you think you should do. And on that note, I'm going to close it down and open it up to questions.
Thank you so much. This was such an amazing session to end the semester on. We love the cases and the diagnosis that you went through. It was amazing. Thank you.
Yep.
There were a ton of questions in the chat. So we'll try to get through as many as we can the next 10 or so minutes. I think one of the most common questions that we had when you were talking about Botox and kind of cosmetic procedures was, what are the differences in what a dermatologist can treat cosmetically and what plastic surgeons treat cosmetically?
So a lot of it is similar. Like when it comes to the Botox, fillers, lasers, chemical peels, the body contouring with cool sculpting, M-Sculpt, cool tone, it's all the same. However, what plastics does differently is they do a lot more surgical interventions, like breast augmentation, tummy tucks. We are more the non-invasive doctors, and I would say plastics is more invasive. That doesn't mean your plastic surgeon won't do the non-invasive stuff. A lot of them are transitioning over, but we are not trained in doing those heavy-duty facelift, breast augmentation type procedures.
Okay, thank you for that clarification. There were also a lot of people asking about Accutane, and so one of the questions that we had about Accutane was, what would you recommend for someone who has finished Accutane and then has those hyperpigmentation, scarring, Would you recommend doing kind of laser treatment, or what is your recommendation?
Great question. So usually post-Accutane, the medicine does a great job of clearing the skin, but you have to give the skin a chance to heal afterwards. So I give it 6 months. I want to see what their skin is going to do on its own. After 6 months, we talk about interventions. A lot of the post-inflammatory hyperpigmentation honestly goes away, and I can always give them lightening agents. It's the actual deep scars, the ice pick scars, the boxcar scars that don't go away. Laser is an option, CO2 ablative laser, but honestly, the newest technology in 2020 is the radio frequency microneedling. That works amazing for post-Accutane scarring, and it can really help clean the area. For some people, it might even be a combination of the light-based treatments and even doing filler in the individual spots to kind of lift it up. It does depend on how the depth of the scarring varies.
Great, thank you so much. We had a question, as you mentioned, about doing really well on step 1. Since, step 1 is moving to pass fail, how do you think that's going to be impacting the emphasis on step 2, or, research or other aspects of your first couple years of medical school?
That's a great question. And I've served on the admissions committee for not only med school, but also for residency. And step 1 was really what we used as a filter to give people interviews. That was it. That's all we used it for. As it's moving toward pass fail, the biggest challenge that is going to be is people are going to have less ways to stand out, which means they need to be more competitive with respect to research, with respect to their letters. That step 2 is going to mean more now. And also the grades, because a lot of places used to have pass-fail grades, and now they're actually grading them. AOA status. I would just say, if you're interested in dermatology from day 1 of medical school, you want to be the best of the best. It doesn't hurt. If you decide you don't want to do dermatology, you can get into other fields. But derm is one of the most competitive fields. So by setting yourself up right, you have a good chance of matching.
Great, thank you so much for clarifying that. We had a question that was asking about if there are any hormonal causes for acne in men that you see.
So in men, usually, unless their testosterone levels are elevated, there aren't as many hormonal causes. But what we usually do is if we do a course of Accutane and a guy or a girl doesn't improve, and they improve while they're on the medicine and then the acne comes back, we do send to endocrinology to do a workup and see, is there any other reason for the acne? Because Accutane does not help hormonal acne. It treats acne vulgaris, which is your run-of-the-mill kind of acne. And that's when you have to kind of take a step back and see, do we have the diagnosis correct?
Great, thank you for that insight. There were a ton of questions asking about Mohs surgery. And do you yourself do that for like skin cancer removal, or is that something, I think you mentioned it was an extra fellowship that you have to do?
Correct. So I do not do Mohs surgery. I have 2 Mohs surgeons 2 doors down from me that do that in my office, but it is an extra year. So I was trained in Mohs when I did my dermatology residency. However, in the Northeast where I practice, you do need the fellowship in order to do Mohs. I am not someone who likes to do exclusively surgery, so that's the only reason I didn't do it. But if you're someone who enjoys surgery half of the time, I think it's well worth it to do that extra year. And you can still do general dermatology. I have a friend who's down in Houston, actually. She's doing 2 days a week of general derm and 2 days a week of Mohs. So it's doable.
Okay, great. That's good to know. A lot of people were kind of wondering on that clarification. There was a really interesting question. What are your thoughts on at-home derma rolling? If all the proper precautions are taken, can it be done efficiently and rejuvenate the skin, or should we go to you?
Don't waste your money. Don't waste your time. I have to say, it's a craze. It's on Instagram. It's on YouTube. There is no data or evidence to back it up. Just go to your board-certified dermatologist or plastic surgeon.
Great, so now that we have that clarified, there's always this question, but just if you know anything about the difference between the DO route going into dermatology, if it's even more competitive than just the MD, if you even see any DOs in dermatology that often.
It's a little different. So I'd say the MDs have their own structured ACGME certified residencies. DOs, it's not the same. They kind of work in a private practice with someone. In my opinion, they don't get as much exposure to the vast array of diseases that you would get if you're in a full MD residency. That doesn't mean as a DO you cannot apply to an MD residency, but it's just that much harder because you're taking the top 2% of every medical school class and they're applying to derm. Now you're coming in as someone who had different training, trying to get that spot. So you have to be extra good to be able to get it. But once it's all said and done, because I have a couple DOs in my neighborhood that practice, when it comes to general dermatology, I think everyone's in the same page. It's what you do with it after you're done with residency and how you really make a name of yourself. Because there are some excellent DOs out there and ones who are just doing the bare minimum basic general derm.
Great, thank you for clarifying that. There was a ton of questions asking about how you would identify skin cancer or any other lesions on people with darker skin tones and how it's different than, lighter skin tones.
Great question. So for people who are lighter and are tan on the day of the visit, I have them come back when they're not tan. So the skin checks in the summertime are reserved to people who are not tanning. But in individuals who have darker skin like me, things do look a little bit differently. The pigment patterns are very similar. However, everything just looks darker. So a dark brown mole in me, not a big deal. If someone is as white as, say, Snow White, that could be a big deal. And this just comes with a lot of training. The more you see it, the more you get accustomed to it. And if I have a doubt, I just biopsy it. Better safe than sorry.
Okay, that's really good to know. There was, I think when you're talking about Donna's case with the Botox, there was people asking about, do you ever have to reject patients who come to you with unrealistic expectations, and how often does that really happen?
So I don't market myself as a cosmetic dermatologist. So thankfully, I don't need to reject that many. It's usually one of my own patients who then asks me about the cosmetic piece. And then if they're a good person, I offer it to them. If they're not, I refer them to somebody else. But it happens more often than not. And you do need to have an honest discussion with them. I would never necessarily reject them, but I might tell them, you know what, we can do it, but you're not going to get the results that you're looking for. And I need you to sign 5 pieces of paper to cover myself and make sure that if she doesn't get what she wants, she's not going to come back angry.
That's fair. That's completely fair and valid. So there was I really like this question. Kind of going back to the acne, someone asked, or like depression and anxiety sometimes are common in youth with acne. And so they wanted to know if, as a dermatologist, do you regularly ask about mental health in your practice? Is that something that you'll ask patients when they come in with acne or other anxiety-prone skin diseases?
So I do in my practice, mainly because I'm an academic medicine doctor at heart. So I treat a lot of conditions like eczema, like psoriasis, like acne, where there is that mental health piece. So I always ask about it. And if there is anything that I find there, that makes me more likely to consider a more aggressive therapy. I'll be honest, many of my colleagues who see 90 patients a day, they're not going to be asking about that. So as the next generation, I would hope that you guys understand how important it is and incorporate it into your practices.
Absolutely. That's hopefully going to be the change. There was a couple of people kind of asking this question, but is it really, necessary? Do you feel pressure to have really good skin as a dermatologist? I know a lot of people are like, I have acne. I don't know if I can be a dermatologist and practice what you preach, but a lot of people are just asking about that, and if that's something that you.
I feel like the pressure has become more of an issue in recent years with social media and just having to look perfect all the time. I do feel like if I don't look a certain way, people aren't going to take my recommendation seriously. Do I think it's right? No, but it's the reality of the world we live in. The silver lining is with the masks, it's less of an issue. No one can see any acne. So if anyone wants to do derm, now's the time to do it.
I guess kind of going off of that, have you seen like a rise in like maskne, like, around here, and overusing, and do you have any recommendations on what to do about that?
100%. For those of you guys who follow me on Instagram, I did do a post on maskne when this whole thing first started, but one of my favorites is a clindamycin benzoyl peroxide combination. It is prescription. That helps reduce the bacterial load in that area. And then in addition, for people who don't get improvement using just the topical, I do give them a short course of an oral medication. But really a big part of it is changing the mask, wearing a cotton mask, not wearing makeup underneath. I know it's hard as girls, but I can tell you when I go to work, I have nothing on. It's just the mask. And that will allow for your skin to breathe better. And as soon as you can, get that mask off and wash that dirt and oil off of your face.
That's great. Thank you. I myself struggle with that. So good to know. I think it's easy to forget to change those masks. So it's a good I guess like one more question before we do our little wrap up is, do you have opportunities as a practicing doctor to serve underserved populations who may not have the wherewithal or the socioeconomic status to come and be treated by a dermatologist?
Yes. So one thing about derm is you can do with it what you want to do. So when I volunteer at Yale and I work with the residents, we actually work with the VA population. I work with one of the homeless shelters in the inner city piece of my state, Hartford. So you can do with it what you want, or you can choose to just see the affluent patients and not really do that. I enjoy doing it because those patients are so much more grateful. And I think you see a lot of cool skin disease and a lot of untreated conditions that can certainly lead to changing the patient's life. If everyone did a little bit, I think we would have less people who are in need of dermatologic care, but absolutely that's an option.
That's great. Thank you for doing that and for using your power for good. I guess the last question that we have for you and that we'll use to wrap up is, what advice would you leave us pre-med students with, going through this COVID pandemic and hopefully, which will be ending soon, but what would you leave us with?
I think the most important thing to remember is with this pandemic, even though we feel like we didn't get to do a lot of what we had planned this year, we have appreciated everything that we have and everything that we've accomplished. And you guys have already done so much to get to where you are today. And the fact that you're planning on going into this medical journey is amazing for the future. So just stay positive, keep trucking through, and know that in the end, your hard work will pay off.
Thank you so much.
Thank you. We appreciate you being here. And also thank you for being our final physician for our 2020 semester. This was such a great way to end our last session of 2020, and hopefully the worst year ever. So we appreciate it so much.
Of course, it was my absolute pleasure to be here. And like I said, I left my email. If any of you guys have questions, feel free to reach out to me.
Of course. And hopefully we'll see you next